Our next speaker is Dr. Jackson. It's good to see you, Dr. Jackson. This is our first year with a Palliative. You can come on, Palliative Supportive Oncology Talk, and we're really excited to hear what he has to say. Dr. Jackson and his team have really helped our program expand the spectrum of care for our patients. NCCN, actually, I was just reading or reviewing some of that, was recommending that all patients diagnosed with pancreas cancer should have the opportunity to speak with someone in palliative and supportive oncology. Even though he's Canadian, we don't hold that against him too often, Canadian and with a beard. But Dr. Jackson, we'll turn it over to you. And for those of you that know Dr. Jackson, you have 25 minutes. 25 minutes.
All right. Thank you, Dr. Page, for inviting me here. So he actually called me up and Dr. Page asked me, can you give a presentation, the underutilized role of palliative care? He actually chose the topic for me. So I told him I give that presentation every day. I'd have no problem. So thank you again. Disclose. So when you come to a conference like this one, you usually come here to learn about new frontiers in medical care, learning from experts, new treatment pathways, and usually those are focused on one, two, or both outcomes, living better or living longer. This conference is no different. A brief history before we get into that on what I would call a repurposed therapy. Going back all the way to the 1970s, it was initially trialed as a therapy to promote quality of life, reduce suffering, and end of life. This very unique therapy in the 70s. And the hypothesis was essentially, if medicine cannot add time, let it focus on adding quality. And if it cannot add quality, let it at least reduce suffering. And that was their theory in the 70s when they utilized this. And it essentially focused on this one principle in medicine, that as the seasons of health change, help the people we care for address appropriately. So in the 70s, we started off with this model for a hypothesis. And then in the 80s, we had this great idea that clinicians in the medical field, we attempted to repurpose this once again, broaden the use of this therapy. And it was essentially with a new hypothesis. If quality of life can improve in the last chapter, why stop there? If the gold standard of medicine is essentially to achieve two goals, to live longer and to live better, why can't we take some of our treatment resources that we use to provide the term was coined, the good death by Dr. Ira Byock, why can't we use that to provide the good life? These are our therapeutic goals of all the patients that we care for. They want to add time, but they want to add value. So many of the things that are important to them on one side of the screen are equally important on the other. Function, autonomy, dignity, quality, cognition, these are also important. So again, going to the 70s, then the 80s, we repurposed it to more focus on life. Interest in anecdotal support grew in the 90s, and it started expanding. Hospitals, clinics, everyone was using these therapies. And in the 2000s, they said, you know what, if we're actually going to use them and anecdotally they're helping, why don't we actually start studying them to get some good data? And some of that data did come out and it was very supportive of its use. We started to see better quality of life, improvements in patient advocacy, autonomy, reduced burdens of treatment, living longer even was discovered in one study. So we're seeing with this treatment, people were living better, improved advocacy, autonomy, they were living longer. And again, looking back at that, it achieves all of our goals that we've tried to achieve. And if it went to the FDA based on this data, it probably would be approved. It hasn't been submitted to the FDA yet, but in time it might. And then in 2016 was a landmark year where the American Society of Clinical Oncology, they had an expert panel for practice guidelines. And they came out and said, this treatment should be provided alongside active treatment of cancer. It should be administered both inpatient when hospitalized and in the outpatient setting. It's very safe. And as you'll hear very often from medical oncologists, a lot of cancer treatments, they have to be put on pause when people are acutely ill. They said, we'll put this one on pause, but these other therapies, they can continue. So for newly diagnosed patients, they also said with advanced cancer, therapy should start within 8 weeks. Greater focus was put on patients with cancer with high symptom burden and or unmet physical psychosocial needs, particularly in the outpatient setting. So here we go, all the way from the 70s, where we were very much focused on quality of life at end of life, through the 80s, expanding upstream to live better, longer, and better, through the 90s, where this started growing in popularity, heavily studied in the 2000s, all the way to 2016, when ASCO created a recommendation that patients should use this therapy within 8 weeks for advanced cancers. Name that therapy, everybody. So here we go. Does anyone know surgical oncology, medical oncology, radiation oncology, gastroenterology? Here's the tough ones: palliative care, palliative medicine, supportive care, supportive medicine, supportive care medicine, supportive oncology, palliative and supportive medicine, or none of the above. So there are a lot of potential right answers there, as you'll see. A lot of different names. So what's with the name changes? Is there a better way to summarize our service? Why have we constantly tried to reinvent our name? So instead of focusing on what we're called, ASCO focuses on what we do. So they are focused on relationship building. They're focused on symptom distress, functional status management, pain, dyspnea, fatigue, sleep issues, nausea, constipation, exploration of understanding and education about illness and prognosis. So encouraging patients' right to self-determination and autonomy, clarification of treatment goals, assessment and support of coping needs, assistance with medical decision-making, coordination with other providers, provision of referrals as indicated. However, despite these guideline recommendations, we've seen lack of awareness. The study came on national survey, lack of awareness and common misconceptions about palliative care among adults. Early integration of palliative care alongside disease-directed treatment can improve quality of life. However, despite increasing demand for services, palliative care remains underutilized and misunderstood. Why? So that's the big question. So the survey tried to answer it. Inadequate knowledge and misconception leads to apprehension amongst patients and has been identified as barriers to the use of palliative care. Many wrongly believe palliative care is the same as hospice or associated with end of life. These misconceptions may also influence not just patients, but providers. They've also reported they worry recommending patients to palliative care could result in loss of hope. It could lead to them to believe that their provider is giving up on them. So we have this vicious cycle of people not seeing palliative medicine, where within the community, they potentially don't understand the role and benefits of palliative medicine and mistake it for other services. And then that leads to doctors or other clinicians not wanting to abandon patients, seeing referrals end in mission of failure, fear of upsetting patients. It's a vicious cycle. So I have this video here.
Hi. We got a call that this house is on fire. How can we be helpful? Well, the house is on fire, but I'm worried if you go in there it might send the wrong message. Wait, what? I'm with the fire department. Yes, I know. I think you could be really helpful, but I think the family might be worried something is wrong if the fire department shows up at their house. But something is wrong. Their house is on fire. Do you think there's any way you could talk to them, but not use the word fire? What? I just think if the family hears the word fire, they might lose hope. But I am with the fire department and I am here to help this family with their fire. Right, totally. I think you could be really helpful, but I'm just not sure this family is in a place where they're ready to meet the fire department right now. Can we call you the water support team?
So I'm the water support team. So that's oh, technical difficulty here. Sorry. Sorry, everyone. Let's dwell on that last video for a second. So the question is, ultimately, there's a lot of misconceptions about what we do and how we help patients. Well, where does it come from? So let's not forget the history of palliative medicine. I mean, there's a lot of good explanations for this. We grew out of a philosophy of the good death. It's hard to shake that, you know? So although focused, we've taken this, we've repurposed it, and we've moved it upstream to focus on the good life, it's hard to move away from that. This study showed that we're definitely misunderstood. Most people, when they think of palliative care, they automatically think of death. Palliative care is the same as hospice care. If you can accept palliative care, you must stop other treatments. Accepting palliative care means giving up. These are what the majority of patients said. Majority of people polled, not just patients, nationally. However, what was also seen was that this is when people knew who we were. But as you could tell from this study, most people didn't. 28.8% of people surveyed knew who we were and what we were. The other 71.3% had no idea who we were. Now, herein lies the problem. Where is the public getting their information? Google, their doctor, American Board of Internal Medicine and Specialty Classification. And I'll tell you, I'm board certified in hospice and palliative medicine. I still have no idea what hospice medicine is. No idea. I don't know, but that's my board certification. So if you look me up, it says board certified, hospice and palliative medicine. No idea what hospice medicine is. But these associations determine what patients' thoughts are on us. Look at Google. I Googled, what is palliative care? This was the first thing to come up. And as you can look at the very bottom, what is palliative care? Bottom right, providing comfort at end of life. So if you look at internet searches, look up your doctors, it can give the wrong impression. How can we fix the problem? Well, part of this, I'd say anecdotally, location, location, location. This study said integration of palliative care physician and a clinical nurse into a clinical oncology clinic with shared workspace, possibility of same-day visits. How did that impact outcome? Effect on the number and timeliness of referrals for early palliative care consultations compared with a freestanding palliative clinic. So integration. I myself have my clinic inside of an oncology clinic, and I will tell you from my own experience, it helps. I can't tell you how many times I just introduce myself by telling them I'm their oncologist neighbor. So, and it helps. But it helps them as well because they say out of sight, out of mind, but if I'm always in your face, you're going to send me your patients. So what was the outcome? Doubling the number of patients were referred palliative care after the implementation of embedded clinics. So jumped from 9 to 21%. 21% increase in palliative care referrals, which meant that not only were patients referred, but there was a jump in how many of them actually showed up in the office. The time between palliative referral order and first clinic appointment was shortened by a median of 9 days from 4.1 to 2.9 weeks. I think this is amazing anyway, because I can't imagine making someone to wait 4 weeks to come in to see me, especially if they're seeing me for pain related to pancreatic cancer. Just that is mind-boggling to me to have to wait a month to see someone for that. So this increase was not due to increased staffing or availability of supportive care services, but rather through a shift of the location alone. That's amazing. All we'd have to do is create or model an integrated program. Language, language, language. Most people do not know what palliative care is. If they Google us, they're going to get the wrong impression. ABIM specialty, hospice and palliative medicine really isn't helping us either. We've tried to change the name of palliative care so many times to distance the specialty from misconceptions with very questionable success. So Perhaps the crux of this is for palliative care to achieve cohesive integration into a multidisciplinary cancer care team. We don't need to change the name of palliative care, but we need to rethink the narrative of the cancer care altogether. And I'll play you yet another video. This is how.
Knock, knock. Hi, I'm the new med student. Oh, hi, welcome. I'm really glad you're here. Oh, you're nice. Of course. Is everything okay? I don't know. You just finished neurosurgery, didn't you? How can you tell? You just have that look like somebody spent the last 4 weeks smashing your soul into a million pieces. That's about right. Please have a seat. Let's get you comfortable. Okay. How's that? Yeah, that feels nice. Would you like a chocolate chip cookie? Sure. Now, have you thought about your goals of care? Well, I'm not sure. Wait, what? Goals of career, your career goals. I don't know. What's going on right now? This is palliative care. Rotation. This is a palliative care rotation. How about some music? No, I'm okay. A gentle breeze from hush by my...
So that's, I guess, one perception of what we do. So there's certainly the focus of the narrative of palliative care is essentially this one common theme: maximize the lived experience of life as it's measured in both time and value. If there are, in fact, trade-offs, make sure whatever trade-offs are presented are most acceptable to patients. The goal of this therapy is essentially for cancers that are incurable, where you cannot get rid of the cancer, do your best job to fit cancer into life, as opposed to fitting life into cancer. However, now we have what is commonly known as the narrative of cancer care. So, So there's no gentle breeze there. So the question then becomes, and this is the narrative that we usually see of cancer care. A lot of fight language: destroy, kick, be brave, fight until you win, battle. A lot of fight language. And of course, that comes with some very sobering data on the fact that, as we discussed our previous presentation, most pancreatic cancers are found when they're in an incurable stage, which is very sobering. I hope much of that changes in our lifetime, but we'll see. How do you integrate a specialty that is dedicated to reducing suffering and improving quality of life into the narrative of a treatment plan that normalizes it as part of the treatment journey? So therein becomes the question: have we spent too much time with our language changing palliative medicine, supportive care, supportive oncology to try and fit their narrative, or must we rethink the entire conversation about cancer care? Conceptualizing treatment as a violent conquest has birthed a difficult impasse in cancer care. Though the intention is to empower patients along their treatment journey, patients are inadvertently predisposed to feelings of, as the study said, failure, despair, abandonment, hopelessness. Of particular concern for most of our pancreatic cancer patients is when cancer is a life-limiting diagnosis. How could we possibly frame the treatment of non-curative disease as a battle when from the onset these patients are destined to lose? The misplacement of personal responsibility can be both isolating and unfair, while the legitimate emotions of fear, hardships, treatment, and illness deserve to be validated. Fight language may normalize, trivialize, or silence them. People living with cancer need to be heard. Underutilization of palliative care. This is what I would focus on. Number one was shameless self-promotion as a push for integrated model to account for underutilized specialty services. Second is, my second point would be underutilization of palliative care language that remains a barrier to specialty care. Why are we underutilized? Perhaps we need a monumental shift in how we discuss caring for patients, from fight language to life language, maximizing the lived experience of life based on time and value, the two things that matter most to our patients. Why sacrifice any of that? Life language expands the boundaries of cancer care. It discusses the narrative and discussions about narrative cancer treatments. It addresses not just how well a patient is tolerating cancer treatments and how effective they are, which is a very important conversation, but also how well one is tolerating cancer. Pain, dyspnea, sleep disturbances, mood, nausea, constipation, poor appetite, anxiety, depression. Treatments can be quite safe and quite effective, and patients will still live with these symptoms. The goal is to maximize lived experience of life by minimizing the lived experience of cancer. Avoid language that normalizes any form of struggle. We're trying to create therapies that have no side effects, not normalizing side effects. So this should be an equally important component of cancer care alongside maximizing the lived experience of life as it's measured in time. Reinforce the ever-present goal of best care possible along the entire cancer care continuum, but explain that there is a fluid means of achieving that best care possible, yet it still remains maximizing the lived experience of life. And as we said, this philosophy was born out of the 70s, that as seasons of health change, help the people we care for dress appropriately. This is the old model. It was essentially a life continuum. You had cancer care, and then that stopped, and then you had hospice care. We are getting away from that, hopefully. Moving towards the old model, there was no measurement in care. The new model, you feel that's like a cup full of water, the whole box, and you want to get that all the way to the top. And as you'll see, it's a combination of two phases, the cancer-directed phase and the symptom-directed phase. And within the cancer-directed phase, you're going to see multiple specialists, those that are focused on time-prolonging treatments, and those that are focused on quality of life and value-based treatments so that people can have their maximized lived experience of life. Time-prolonging treatments essentially continue as long as they are safe, as long as they are effective, and as long as in your thorough discussions with patients, they have acceptable risks or trade-offs. But as we know, that box continues to shrink along the life continuum, where the safety of these medications potentially becomes less, the efficacy of them begins to shrink, or perhaps the acceptable risks and trade-offs involved continues to get much smaller. And during that time, you'll see on the right, what potentially continues to grow as that safety and efficacy or risks and trade-offs continues to get smaller. Burdens of disease and burdens of treatment continue to grow. So they're proportional. And as one shrinks, the other grows, and that's how you would continue to achieve 100% care. The symptom-directed phase is quality of life and value-based treatments alone. So the cancer-directed phase essentially tries to fit cancer into life primarily by maximizing the lived experience of life as it's measured in time. There are going to be anticipated quality of life trade-offs because many of these therapies often have side effects, and often your cancer could have serious symptom burdens. So our job within that phase is to minimize your quality of life trade-offs in that pursuit. Sometimes I describe it like a burning hot oven, and you've got your dough and you're trying to bake that dough, and it's a violent environment. It's very dangerous, but it has a utility, and you watch that dough very closely to make sure that you're baking bread. But you want to pay very close attention because at snap of a finger, that you leave it in that oven for too long, that bread very quickly starts to burn. So because of that, because there are treatment-related burdens, you want to always make sure that your therapies are safe and effective at an acceptable risk and benefit. The next phase fits cancer into life primarily as it's maximize the lived experience of life as it's measured in quality, understanding that time is however much we have. Where does hospice fit into this? So hospice within the symptom-directed phase is essentially there's an understanding that it should be a maintenance and escalation pathway, continues to meet a patient's growing clinical needs without having to increase treatment-related burdens. And the expectation is that you're meeting comfort-focused, value-based goals with the expectation of illness-related decline. So you'll see that clinical needs will continue to grow, and therefore you will continue to be able to meet patients' goals of best care possible by needs meet their goals, or needs are clinical picture has clinical needs met. And that should continue along an escalation pathway. So in summary, the diagnostic phase, the focus is intel gathering so that an appropriate plan can be established. Team is tumor-directed specialists, symptom-directed specialists. That's prior to this. The cancer-directed phase focuses on maximize the lived experience of life as it's measured in time while attempting to minimize the anticipated value-based quality trade-offs from burdens of treatment or burdens of disease. Your team that you have in this phase is tumor-directed specialists and symptom-directed specialists. This phase continues to be best care possible based on 3 criteria, or until 3 criteria are met. It's no longer safe, it's no longer effective, or it has unacceptable risks. Symptom-directed phase maximizes the lived experience of life as it's measured in quality, maintains low burdens of treatment and low burdens of disease. Your escalation pathway there should continue to meet a patient's growing clinical needs without having to increase treatment-related burdens. Achieving best care possible means meeting comfort-focused goals with the expectation of disease-related decline. And your team there is going to be symptom-directed specialists, once again, with hospice. And within each of these phases, as we said, ASCO guides us on the type of care we should provide. Building rapport, symptom management, patient education to improve self-advocacy, clarification of goals, coping support, assistance with decision-making, coordination of care, and referrals. Ultimately, this is what we seek as a multidisciplinary team. Not just us, but within an entire team, we all have tools in our toolbox to achieve this one single goal. So just take home points here. Palliative care, or whatever it's called, I don't know. So it's a novel therapy demonstrated to be effective in helping patients live better, or maybe even live longer, and is recommended by ASCO guidelines. So if you really just stop there and say, what's the underutilization of palliative care? It's guideline driven. Why aren't we using it? Well, because there's still reservations amongst the community. That's where the second aspect of that comes in. Location, 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 and I can speak for myself, this very much helps in creating an integrated program. Focus less on what we're called and more on what we do. The key to doing this isn't changing the name of palliative care, but rather changing how we discuss cancer care altogether. Reframe the cancer care continuum narrative using life language. Best care possible will always focus on maximizing the lived experience of life. Minimize feelings of abandonment as care plans change by reinforcing that the tools of the teams to achieve best care possible are dynamically updated along an evolving illness process. As the seasons of health change, help patients continue to dress appropriately. And life language should never take away hope. Rather, health professionals help patients guide their hope in the direction of best care possible. The unacceptable alternative would be fight language that may actually steer patients into harm's way. It is challenging, and I would challenge everyone here with this question. How would you integrate a medical specialty that is dedicated to helping patients live well into a treatment narrative that normalizes human suffering as part of the treatment journey? It's time to start focusing on life language. And with this, I'll leave you a small quote. Conversations of clinical care are often guided by laboratory and imaging tests. Context is easily lost in a sea of medical investigations. The end result is that we fixate on the appropriately worrying question of whether cancer is progressing despite treatment, but inadvertently miss the opportunity to address whether life is progressing despite cancer. Thank you.
Thanks, Dr. Jackson. I'm really glad we had you come. I really appreciate that. Incredibly thought-provoking. As some surgeons like myself and people who have worked with me know, when you're operating, I've told many of my trainees and APPs that if you're not angry, you're not going to get this thing out. And I think the balance that you're talking about is what we need more of. So I appreciate that. We do have time for a couple questions. Any questions? Yes, ma'am.
Deborah again, thank you so much for that presentation. It was amazing. I have a question in reference to what you were talking about. So if someone lives through the disease, right, they've gone through the cancer process, they actually have a chronic disease, right? Because they're still going through the and fighting, not fighting. I'm sorry, I didn't want to use fight language, but they're still going through the disease. How do you see palliative care after someone is going through the disease and they've done their Whipple surgery, they've done their 12 rounds, they've rang the bell? Do you see palliative care in that process afterwards? Or is that just people just going through it and end of life? So I'm just trying to understand.
I'd probably divide it as a divergence between those who are living with an incurable cancer for as long as they can to maximize that lived experience of life, and the smaller percentage, I believe it's about 10% of patients that have a curable pancreatic cancer. So with those ones, I'd say there's still an additional role. There wouldn't be a differentiation, but it would be more about survivorship support. Yeah.
Dr. Szabo.
Hey, so I'm going to push back a little bit about the underutilization of palliative care, because I personally think to some extent it's your specialty that is the issue. And not that I'm a very big supporter of palliative care. My issue is that there are many patients and there are few of you. And that's the problem. So when you talk about I'm embedded in an oncology clinic, that's the ideal, but that's not the reality. When I was at Emory, there was palliative care. They were quasi-embedded in our clinic, yet they would see the patient once a month, once every 2 months. And yet I was seeing the patient every week. And I, you know, as we all know, for the people who are suffering from this disease, who take care of this disease, things can happen daily. And even seeing a patient weekly often is not enough. I absolutely agree with the fight language. I was having a meeting with patient. The patient was drifting psychologically, so I need to have a family meeting with them. And I basically, they were using words like, am I getting aggressive treatment? Am I, you know, and I basically stopped that conversation. I said, we're using appropriate treatment. I don't want to use words like that because they are not helpful. Good versus evil, things of that nature. But my question for you is, when is your specialty going to work on workforce? Increase the workforce? Because really you just need more of you. It's not that what you do isn't invaluable. It is super valuable. It's amazingly valuable because I can't do it all alone. It's just too complicated now. It's always been too complicated. But I've worked in big hospitals and small hospitals or smaller hospitals, and there's just not enough of you. So how is your specialty going to increase the workforce? Are you going to use more? Are you going to educate internists? Are you going to educate nurse practitioners, PAs, et cetera?
Yeah, that is a great question. And actually, that was one of the things I was going to focus on in this lecture. Is the underutilization of palliative care is not just primary specialty palliative care. It's I looked up how many fellows graduate from palliative care programs in the United States. And then if you look up how many patients are diagnosed with advanced illnesses that meet criteria for ASCO guidelines to see us, it's impossible. It's impossible. lucky enough that I work with medical oncologists who their primary palliative care skills are fantastic. And there will never be enough of us, which is why I think ASCO's guidelines, if you look up what they recommend palliative care to do, I often encourage even medical oncologists, and the ones that I work with certainly do, achieve many of these goals that ASCO set out to expect palliative care services to provide. The challenge is going to be how do you match the number of specialists to the number of patients? I don't know if there's ever going to be a good answer to that, because if you look up, let's say, fellowship matches for medical oncology, it's always actually like 100%. If you look up palliative care, I don't think they're reaching near 100%. There has to be a generated interest in doing that. Even now, however, they're starting to provide joint programs where you can actually get a fellowship trained in both oncology, medical oncology, and palliative medicine, so that you can achieve both. Is that an answer? I think it's probably a fix, but I think we'll probably see more hybrid training models in the future because of these limitations.
Thanks, Dr. Jackson.
Oh. Thank you.